أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم Alhamdulillahi Rabbil Alameen. In the name of Allah, the Beneficent, the Merciful, all praise is due to Allah, the Lord of the worlds. Peace be unto you. Assalamu alaikum. We want to welcome our friends in South Africa, the United States, and around the world to this week's edition of A Conversation with El-Hajj Mauri Saalakhan. I am pleased to be your host, coming to you once again through the Salam Media platform out of Johannesburg, South Africa. Salam Media is an online portal for humanitarian journalism. We don't just report the news, we advise you on what you can do about it. We have another very special broadcast scheduled for our listeners and viewers this afternoon, this evening in South Africa. Our topic for today is the coronavirus pandemic, a global update. For starters, protesters gathered outside the opening ceremony of the Summer Olympics in Tokyo, Japan, where the International Olympic Committee pushed forward with holding the games despite widespread opposition. Polls show at least 70% of the Japanese population wanted the games canceled or postponed. At least 110 people linked to the games have tested positive for COVID-19 so far. Meanwhile, here in the U.S., the Centers for Disease Control and Prevention warned the country is at another pivotal moment in the pandemic, as it urged, unvaccinated people, especially young folk, to get shots to protect themselves and their communities. Hospitals are issuing warnings that things are likely to get much worse as a result of the variants and a slow down pace of inoculation. One CDC expert opined, quote, "The Delta variant is much more contagious. It's making people sicker. It's getting into a younger population. There is a lot less mitigation in place than last year," end quote. In Los Angeles, California, officials said 20% of new cases are now being reported in vaccinated people as the Delta variant has taken hold. To help us navigate the complicated shoals of today's conversation, I'm pleased to have as a return guest Dr. Velva Boles. A brief introduction. Dr. Boles is a physician scientist who has practiced clinical medicine for 25 years in Louisiana, South Carolina, and Missouri. She is certified by the American College of Forensic Examiners as a medical investigator. Dr. Boles earned her bachelor's degree in biology and chemistry from North Carolina State University, her master's degree in inorganic and organic chemistry from Duquesne University, her doctorate of medicine from the University of Pittsburgh. She also has a doctorate in health sciences from Concordia University. Dr. Boles had postgraduate training at Colorado State University in molecular biology, gene regulation, and a medical residency at Tulane Medical Center. She has been an adjunct professor at LSUA in the Department of Mathematics and Physical Sciences and at Upper Iowa University in the biology department. Let me also add that she has a passionate concern for the medically underserved, especially for the chronically underserved and marginalized from among her own tribe. Dr. Boles, welcome again to the program. It's good to have you back.
Thank you. I've anticipated this moment for some time now. I'm always excited to share what knowledge and thoughts I have with the world.
Dr. Boles, you were part of an international webinar a few nights ago. How did that webinar impact you and why?
Well, the information that was shared, let me just back up for a minute. There are frequent international webinars among scientists and clinicians. And these discourse are those among academic persons and practicing physicians who feel that they are not being heard, that the information provided to the masses are coming from the media. And the media tends to chop information into small bites and certainly put a spin on it and then present it. Initially, when COVID-19 first was announced as infecting humans, the clinicians and scientists followed the tenet that we were taught. You collect data, you evaluate data, and then you make a decision. Unfortunately, the COVID-19 infection information became politicized, and the media, television, radio, other sources, social media, and Facebook, Twitter, they took the lead. And so much of the information was hybridized or changed to conform to whatever perspective that the media needed to get better ratings or to boost someone's followings. So the information provided was not vetted, and often the professionals who could have spoken more intelligently were not consulted. So here we are 18 months later, and the clinical and professional organizations finally woke up and said, we can't wait for CDC or WHO to provide the people with the best information for them to protect themselves. So webinars such as the one you described are not new. They're usually infrequent, and of late they've become rather frequent, and the persons on such calls are from all over the world. We get the biologist, a Nobel Prize biologist was present. We have World Bank economists present, a number of scholars from various institutes, a number of intensive care physicians, and believe it or not, veterinarians. I have spoken previously to other groups saying that it is clear that the most knowledgeable professional about coronavirus have never been consulted, or at least not vetted through mass media. The veterinarian doctor, who is a doctor, I mean, I don't know why in Western medicine they tend to be so segregationist. But the veterinarian physicians have worked with coronavirus for many, many decades, because it is usually the cat, the dog, and other animals that corona affects. And that corona now affecting human, its behavior is not so different. The difference is that it crossed into human population. And that's where the speculation about how this virus originated. Why and how did coronavirus cross into the human? And that's a debate and a controversial debate that you may hear Dr. Fauci and others gather into. Right now, that's not my focus. My focus is, if the intent is to stop the pandemic, I am extremely frustrated to watch the decision of WHO, CDC, and other powers that be offer a single solution. I know, and many that I have discussed with, like in the webinar, know of complementary processes by which the spread of this virus with all its variants can be stemmed. Vaccination is one way, not the only way. And it really surprises me that there is no offering of the others. And if you ask what others, convalescent antibodies can provide protection to a person who cannot launch an antibody response to a vaccine. These convalescent antibodies can come from someone who has already had COVID-19, as well as those who have been vaccinated. So there is an alternative, effective pathway of protecting people and not simply standing back saying, if you don't get the vaccine, you'll get sick and die. That to me sounds very extortionistic and rather bullyish, because we also know that medications such as ivermectin has been proven, not speculated, proven to give anti-inflammatory assistance to persons with all kinds of maladies like dengue fever, malaria, and other type of tropical diseases. There has been evidence through laboratory testing and clinical trials that ivermectin provides protective, prophylactic support to persons who do not have access to the alternatives such as vaccines and convalescent antibodies. But there has not been a concerted effort or a presentation at large. They're not saying, okay, healthcare establishments, let's come together and let us talk to the people. It seems WHO can be influenced. It seems FDA can be influenced. Recently, the American Academy of Pediatrics took a stance in America saying children should be masked. They should not have an option. So they finally are speaking out against the WHO CDC recommendation out of their own experience and training. In my opinion, the persons who have gone to school 12, 15, sometimes 20 years for their specialties and fellowships, they should be the ones speaking. Likewise, those who represent underserved populations, all kinds of jargon, marginalized population, the disparity of care among this population. If I say it frankly, I'm talking by my experience, a Black American diaspora. Who are they? There are those who are Black Americans in the United States over 400 years. There is no tribal home. We are Americans. Unfortunately, we're also subjected to a lot of deficits. And among those is healthcare for what they had referred to as comorbidities. So those who have comorbidities, those who are marginalized, may not have the capacity to respond to a vaccine. This is already known, it's accepted, and no one addresses it. So persons who have diabetes, on dialysis, hypertension, lupus, MS, organ transplant, and so forth, they have marginal response to any kind of invader, whether it's a vaccine or an infection. What is my proof? Diabetics have the highest amputation rate of any group. Why? Their body does not heal well. So proof that they cannot launch a very good immune response. The only comment made to that when you talk to the mass media or the voices of CDC and WHO is we will give them a booster. So they're saying if one shot doesn't work and 2 shots don't work, then 3 shots should work better. And my training is if you keep doing the same thing and looking for a different outcome, that's called insanity. Mm-hmm. So when I look at the underserved healthcare population in America, and we do have that, so world, please know that's the real thing. Everybody in America does not have insurance, does not have equal access to the state-of-the-art healthcare. There are some who are relegated to taking medications by formulary, which means restriction, and those who are not privileged to have a primary care doctor with whom they can discuss their fears, their concerns, and their health. So from the perspective of America, I know such population, I work among them, and my advocacy is we need to have complementary offerings to protect those who cannot respond to vaccination, and not simply demonize and say, oh, you must be vaccinated, or it's your fault if you get sick, or only one's dying is unvaccinated. And I challenge to say, in this 2021, we have alternatives. So if these persons are dying because government officials have decided or drawn a line in the sand, then the death is on you. I've had a person say, well, Dr. Bose, where would you get convalescent antibodies? Isn't monoclonal antibodies too expensive? Please know that the vaccines are not free. Pfizer's charging $30 per shot for its 2-shot program. The government, United States, and whomever else is purchasing these vaccines from Pfizer, Moderna, AstraZeneca, Johnson & Johnson, they are paying those fees. And in the US, that's taxpayers' dollars. It's
right.
not free. It simply means you can go to Walmart or go to your church or go to a clinic and they will give it to you and you don't have out of pocket, but the money is your taxpayers' money. It's not free. So if they can purchase this vaccination inoculum from different pharmacies, they have the same ability to purchase convalescent antibodies or special design monoclonal antibodies or multi-clonal antibodies. That is a protection that is available. We already have the institutions that are capable. In fact, the blood banks could even set up to allow you to donate convalescent antibodies. Just imagine, Mauri, that like you can go and donate blood for a friend or a police officer or someone who is in the hospital about to have surgery. Wouldn't it be nice that you could go find out you have antibodies and you want to donate your antibodies to your auntie, your uncle, your grandmother, your brother, your sister, and know that those antibodies, listen to the term, can protect, not stimulate, protect you against the infection, because the antibodies in my body will work just the same as it will in yours as blood transfusions do. So I don't know why that's not an option, but to answer the question you asked, the international group came together to discuss, mostly they needed, I guess you'd call debriefing. Among the many specialties, the discussions rest on, have we been silent too long? Should we have made clarity and interjections to stop some of what has become politicalized? So it wasn't something that would be a direct repeat to the public, but it was most concerning to me to hear very scholarly people lament that it wasn't their voice that was telling the story, and the people were, in their opinion, getting very focused and narrow information and not a complete effort to stop this pandemic. I hope I answered your question.
Yes, you did. You mentioned the alternatives, and one of them being monoclonal antibodies. I came across, in the days leading up to this conversation that you and I are having, I came across a piece of video that I want to show right now. It's a pretty well-known comedian in certain circles by the name of Colin Quinn. Brother Sadiq, please show that video.
Colin, I really thank you for coming and talking with us today about monoclonal antibodies. We've spoken before, but what's really, exciting to me is to be able to get the word out. You're someone that people know and name they recognize. And if most people don't know that the monoclonal antibodies is probably our most effective treatment we have early on in COVID. It's the one treatment that we have that prevents hospitalizations, actually 75% reduction in patients at risk. And where it normally takes a couple of days to weeks to start developing antibodies, which are your body's natural immune system to fight the infection, the antibodies really give you a jump on it and allow your body to fight off the COVID before it causes the damage. So getting the word out is really important. So I'd love to talk through your experience and how you got COVID and how we got to it. So thanks for taking the time and talking to us.
Sure. Thank you again, doctor. And it's great to see you. I got COVID from doing a live podcast with younger comedians, which is actually relevant because they got COVID, and the COVID, whatever strain they gave me or I had, they got devastated. I just felt bad. Like 2 days later, I started getting a cold. This is in around Thanksgiving. And I started feeling like sniffling. And I was like, oh no, I can't have COVID. I can't have COVID.
what concerned us was like Dr. Goldman called us, your doctor called us, is that, you were already a few days in, you had underlying conditions, and we've seen a lot of patients like you deteriorate. I met you already after you were already sick, but when did you get, you got tested, and then how did you find out that that this was available? Like, who told you?
I called my doctor, and then he said, you're eligible. And then he set the whole thing up. You know what I mean? That was a good thing, Dr. Goldman. So he said, you're eligible, so you can get in there and have it. So I went up and got it. And I wasn't even going to go. At first I was like, oh, it's a hassle. I don't know. It's all the way uptown. I didn't even want to go out. Remember in November, people didn't want to go outside in the city, It was my heart doctor. So I take, you know what I mean? Like, I knew he wouldn't do something that would jeopardize my heart, And he said, this is available. I can get you the treatment. Do you want to do this? He goes, I would say you should do it, but do what you want. Nobody tells you to do anything anymore. So I said, yeah, I'd love it. So he said, all right, I'll set you an appointment. Got back to me, got me in there, and that was it,
The key here is when someone's positive and they're at risk of getting it, you got to give it early. So within the first 10 days for sure, but even the first 5 days. So as soon as they have symptoms and they test positive for COVID and they meet the criteria, get that IV in, get the infusion in as quickly as possible. We're glad we're able to get you in. So, you're a busy guy, lots going on. What motivates you to take your time to talk with me about this?
The people around me that got COVID, I'm the only person I know that got the infusion. So all the people around me, which is probably 20 people I know that got COVID over the past whatever, all of them had a much rougher ride, according to what they said to me. None of them had an easier time than me. And I'm the one with a heart condition. And I was probably the oldest one too. You know what I mean? And I'm not some big healthy guy. So that just shows how the infusion worked.
What did you feel when you got the actual infusion?
I mean, afterwards, it was pretty quick. When I started to feel better, I was like, wow, this is really working. Suddenly I was like on my phone. Suddenly I was feeling better, walking around I wasn't going outside, but I felt much better, just different. You know what I mean? The nausea went away, everything.
Last question for you from me is, well, give me your 30-second elevator pitch now that I can, you're a man that communicates with the masses. Give me an elevator pitch.
You know what I mean? I don't know why people would resist this, because it's such a positive thing. And it's better to play it safe, in my opinion, because, you don't want those clotting things, Right. But I feel like it saved me from really bad lingering COVID. For me, it really worked.
I encourage everyone to, treat.
Okay. Something, Dr. Boles, this alternative therapy should be receiving a lot more attention, especially in places like Brazil and India and South Africa, places that are having a very difficult time getting access to the quote unquote vaccines. And but before even going there, right here in the United States, you pointed out that, the vaccines are not free. They're being, paid for by American tax dollars. In fact, there were huge sums of money paid out to these pharmaceutical companies even before the vaccines were ready. And then you have additional monies coming into their banks as a result of the shots being taken. You would have thought that, the huge infusion of cash into these pharmaceutical companies' bank accounts should have been sufficient as payment rendered. But that is not the case. Again, we're seeing capitalism at its best. But the reality is that for the average Jane and Joe in the street, who is now able to access a vaccine at the corner drugstore or at the church or synagogue or mosque, the impression that they have is that, okay, we're getting this for free. On the other side, when it comes to the alternatives are clearly not being made available for free. And there's even a question as to whether or not the alternatives are going to be accessible for the average person. What is that process like? And is it actually available? Say, for example, someone who doesn't have health insurance, could they go to a clinic, a neighborhood clinic, and make a request for this with a realistic expectation of being able to get an infusion of monoclonal antibodies?
Well, let me take you on a little stroll. In the Internal Medicine News issue, I think it was the February issue 2021, there was an article describing how the FDA, the same FDA that gave emergency approval for the injectables, had gone into partnership with Mayo Clinic, and they had commissioned a number of blood banks within their vicinity. I think the number are 200 blood banks. So in January 2020, not 2021, 2020, they had commissioned these blood banks where you would go and donate. They're the most likely source to donate because they're set up for it. Because to donate convalescent antibodies, and the word convalescent means you have had COVID infection and recovered, meaning you have a natural immunity, meaning you have built immunoglobulins or antibodies, IgG, IgM, IgA, all of the antibodies that your body needed to fight the virus and win. So you are a walking testimony to innate immunity. They were soliciting such people and collecting their antibodies as early as January 2020. Now, the only bit of information released by the media had to say that the convalescent antibodies employed with the severely ill was not successful. If you were attentive to the short video clip you just showed, it isn't the terminal ill that most benefit from such things. It's the early diagnosed. So the population that has been identified with comorbidities would be the target group that should have immediate coverage, because within the first and second day of demonstrated verifiable infection, convalescent antibodies are instant protection, are instantly fighting that virus, because the people who recovered made those antibodies. To answer your questions, can you go to somewhere? If you also listen to your clip, what did he say? My cardiologist said I was eligible. My primary care brought me in. So here we come right back, Mauri, to where I'm jumping up and down saying, the people who do not have a private physician and those who do not have a conversational relationship with a cardiologist, they are excluded from the opportunity that this video person mentioned by virtue of the health, quote, disparities in the United States. Where do they go? Who do they ask is really what you're asking me. And my outcry for the last 18 months is stop waiting for major America to provide this. And I did a shout out and a request. Where are my medical institutions who are historically Black institutions? I targeted, but I'm not limiting to that. Some has said, why are you asking for the medical institutions? Because they're the ones who are accredited. They don't need any extra anything. The School of Public Health at Tuskegee, for instance, or any of the medical schools, let's say Howard, for instance, they already are credentialed by virtue of what they do. So if there were a NIDIS or initiatives that sprung from there, what would it look like? It would be a neighborhood clinic. It may be a university-sponsored clinic, because many medical schools have indigent clinics for people who are underserved and can't pay. And in those clinics, that's how they can focus on the population who've already been identified, and to a large percentage of those persons are people of color in these United States. So you don't have to redefine. It was defined as far back as February 2020, when disproportionately African Americans or Black Americans were dying. Look at New Orleans in March of 2020. Look at Chicago, Detroit, and look at the demographics. They were people of color and predominantly Black Americans. And the whole thing boiled down to the persons presenting to the emergency room had symptoms that were different from what CDC and WHO had defined. And therefore, they kept being turned away. I had prior clinic patients call me and say, Dr. Boles, I took my mother to the ER 4 times before they finally admitted her. And why were they turning her away? You had to have a cough, you had to have a fever before they would consider it to be COVID-19. And it took 6 to 8 months of YouTube videos and Facebook correspondence from NICU nurses and NICU doctors saying, wait, you got this wrong, America. Persons coming in that are so sick or they're dehydrated. Some may have never had a fever. Some never lost a taste and ability to smell. So this virus does not only have those symptoms. So quietly, and this is part of my offense, they didn't come out and announce and say, we were wrong, this is not a respiratory disease, we are no longer calling out for ventilators and companies to start manufacturing ventilators. We've now seen that our first opinion was wrong. Nobody said that. There was no culpability. They simply went silent. And I've had people say, well, Dr. Boles, do you still have to have a fever and a cough? And I said, obviously not, because it's clear the virus attaches to a receptor. If the receptor is predominant in the lungs, you have lung issues. Predominant in the gut, or however it happens to attach, if it's the blood vessels, you have a clotting problem. If it's brain tissue, you have a thinking problem. So silently, without explanation, they stopped telling the public that this was a respiratory disease. And part of going back to the webinar, the scientists and professionals talking, saying, we allowed this to happen, that there were no explanations, people were left confused, and we allowed the American paradigm to be visited on everywhere else in the world. So one size fits all. It's clear that ivermectin, a well-tested prophylactic medication, anti-inflammatory medication, and there has been indications that it could even be preventative for the attachment mechanism of COVID-19. It's totally neglected. That places where the vaccine isn't forthcoming because the industrialized countries first won't tell you their patent formula, so you can't make the vaccine for yourself. Second, there's a political negotiation of, can you afford to buy the vaccine, or are you appealing or making some kind of concession to have a country send you the vaccine? All of these things, in my opinion, says there's no serious attempt to stop the scourge. That the dividing lines of have and have not could serve a bigger purpose, however venomous and heinous that purpose is. So to answer your question, currently there is no immediate single focus, such as you get a vaccine, you can go to Walmart, you can go to Walgreens, you can go to your church, you can go to health service. They've made it widely available. The same complementary effort to protect people who have been identified as poor responders, there is no effort that I have seen that is concerted to the degree of the vaccination program.
Now, monoclonal antibodies, the convalescent antibodies,
they're not the same. Let me help you a little bit. Convalescent, okay, convalescent comes from a person who's had natural infection. Okay. Monoclonal means I can design it for you. Monoclonal antibodies made in a laboratory in various processes, and you can target what you want. So that's your designer antibody. The multiclonal means I have IgG, IgA, and I've reacted against various parts. So you can literally, when you're talking antibodies, get the designer, That's your monoclonal. Or you can get the convalescent. That's from someone who has had the disease.
Okay, now which of these therapies did former President Trump and his Confederates receive when they got COVID-19?
He received from Regeneron, and my understanding it was a monoclonal antibody. So he got the designer.
Okay, all right. Okay, that's good. Thanks for that clarification. Do I recall correctly you saying you can actually get ivermectin in pill form?
Ivermectin can be provided in pill form in countries, and I talk to the African continent now, and I can talk to my Latin American continent areas. Ivermectin is widely used, and when you take it into the field, as you've heard, if you have to keep something in liquid, you have to keep it under certain temperature restrictions, and you have to be very careful not to cross-contaminate. But if you have it in a dry form, usually when it's dry, the processing is a lyophilization, as L-Y-P-H-O-L-I-Z-E-D. When you lyophilize something, you freeze dry it. And if you were to take ivermectin, which we do in the tropical places, it is dispensed in one bottle as a dry powder, and accompanying that bottle is purified water. And when you get to the site at which you're going to use it, whether you're using as usually by injection, but you can use it in other forms, you can add the purified water to the powder and mix it on site. And that's the way in which it can get into very remote areas and not be at risk for breakdown. Ivermectin is very inexpensive. It's been around so long and it's so widely manufactured that in some very remote areas, by virtue of its easy transporting and its ready availability and its low cost, it is an ideal treatment. Prophylactic, the word prophylactic meaning preventive. It has been demonstrated to decrease the attachment phase for the virus. And it has been demonstrated by virtue of other viruses, not just COVID. They've had experience with dengue fever, for instance. That's viral, although it's vector mediated. Zika and other things that international doctors will tell you this is a wonderful medication. Now, let me tell you a bias that stops ivermectin to some degree, in my opinion, in the US. The United States or Western medicine like steroids. We go with Solumedrol, Celestone, dexamethasone. We like steroids. Well, if you ask the most scholarly immunologists, how do steroids work? You won't get a direct answer because we don't know. All we know is it can help reduce swelling, it can reduce redness, and the immunocytes, our cellular immunity system, gets slowed down. We can tell you results, but we can't tell you mechanism. So when I ask, why aren't we using ivermectin? They will say, oh, we're not sure of its mechanistic action. I challenge you. Look at what 1 billion people have done and benefited, and that's what is available to them, but yet you don't authorize the use. And here in America, doctors who are dispensing ivermectin, and just for information, the calculated dose is 0.3 milligrams per kilogram body weight, that they are seeing excellent results, that persons who have been exposed or had opportunity of exposure have been less likely to become ill despite people in their circle. Referencing the video you just showed, he mentioned there was a number of people in the circle that got very ill when he contracted COVID-19. A similar kind of anecdotal reference have been made with ivermectin. But yet it has not been FDA emergency allowed medications. So American doctors who were to prescribe ivermectin, if they indicate it's for COVID-19, that would be considered not standard of care because of political reasons. So how would someone, that was your original question, get the antibody treatment? Ask for it. Because technically, I can give an anecdotal story of how a veteran went to the VA hospital on my advice and asked, he wanted the same treatment as his commander-in-chief, and he got the infusion. Now, is that standard? I don't know. It was wonderful for him. And when you're talking on a singular basis, it's always 100% for one person when it happens. But to my knowledge, there is no organized resource or avenue to constitutively, meaning freely, without inhibition, without connections, get ability to get that complementary alternative to a vaccine. And I think that's terrible.
Dr. Boles, we've been hearing a lot about the Delta variant. To your knowledge, are there any other variants on the horizon that we should be concerned about?
Absolutely. In fact, Delta hadn't left us alone yet. Delta now is 90-some% of all new infections in the United States. It's climbing in the UK. And for those of you who haven't followed the science, Delta originated in India. And during the time it was in India, it mutated again. So we have Delta and we have Delta Plus. In Peru, there is a new one they're calling Lambda. Lambda is now about 86% of all infections in Peru. Lambda has now been found in the United States in one state, Texas. And here's what the variants mean. I like to be clear. The Delta variant has had 3 mutation sites of mutation. Now, what does that mean? If you remember seeing the picture of the coronavirus, you see this ball and these little red spikes sticking out. Well, the little red spikes are called spike proteins. And it is the spike protein, if you like, analogy I would give you, know how Velcro works? You take one and lay the receiving Velcro against the giving Velcro and it sticks. And when you pull it apart, you hear the snagging. Well, when I say attachment, it is similar to that. Imagine this spiky ball finds a receptor on your cell called ACE2, and that's ACE-2, and it, like a Velcro strip, can stick or attach to your ACE2 receptor. And I identify that as phase 1, that it must attach before it can infect. So when we talk about how do you moderate the virus, especially if you're talking naturopathic treatments or Ayurvedic treatments, we talk about the stages. There are something you can do to inhibit attachment. Zinc has been demonstrated to decrease attachment. The uses of aromatic inhalants has been demonstrated to reduce the attachment or reverse attachment. So I'm talking Ayurvedic medicine or Ayurvedic treatments. But going back on point, that spike protein is key to getting the virus inside your body. So what has happened is the spike protein over these last 18 months have slowly modified itself. And that's what we call mutation. So at one time, the spike protein would attach to your ACE2 receptor, but the attachment wasn't so fast. It was there, a little clumsy. As this virus has gone through many, many patients, that protein, if you want to talk epidemiologically, it has gotten smarter. So the fit of the spike protein has changed such that it can bind the ACE2 receptor better and facilitate entering the cell better. I looked at a webinar this morning under Dr. John Campbell. He's on YouTube, and he described that the Delta variant is 1,000 times more effective at entering the cell. And he kept incredulously saying, I can't believe it's that much. He looked at the study from Israel and several other places where they're saying the infectivity of Delta is that many times more aggressive in attaching and infecting. And he reported that there's more breakthrough with Delta. And you said, wait, what do you mean breakthrough? The study came out of Israel where they have 100% or very close to 100% vaccinated people. They started fast. They were very efficient. Second shots are in. That the effectiveness that they found among the Israel is 39%. And you say, what does that mean? It means the Delta variant can infect fully vaccinated people, at least in Israel, because that's where the data is coming out of. And this is shaking up the Tony Fauci's and the Tedros of WHO, because the big belief they talked about was herd immunity. Mm-hmm. By definition, herd immunity says so many people cannot get sick or die from a disease such that you're safe because there's so many people walking around immune to this disease. Well, when it started to have variants, the idea of herd immunity is no longer in effect. I dare you to say who's talking herd immunity on the TV now? Nobody. Because the breakthrough infections kills the theory of herd immunity. And breakthrough infection says, I'm fully vaccinated, I took your messenger RNA, I took your DNA, and I took 2 shots, or I took a 1 shot from Johnson & Johnson. But data says when you're exposed to Delta, the likelihood of you getting infected can be 50-50. So the target, when they first started vaccination, Mauri, I challenged their approach. Why are you immunizing the elderly first? Shouldn't we be immunizing the young 18 to 30-year-olds because they're the party goers? They're the ones that want to go out at night and drink and sit outside. And here was the response. Our intent is to reduce death and hospitalization. Guess what? That's all they have done. They've reduced death among the elderly. The hospitalization has gone down. But the kicker is the persons who were left on their own recognitive until recently have given rise to variants. And the variance changes every rule in the book.
Mm-hmm. Any thoughts on pandemic-related developments taking place in Cuba? Long a target of U.S. instigated political unrest.
Wow, I have nothing but admiration for Cuban medical establishment. The persons I've met who have been trained in Cuba are stellar. And just seeing how under the adverse, embargoes or sanctions is placed on them, they are still excelling. What do I mean by excelling? As you saw in the early phases of the pandemic, they traveled to help people in New York City and other places. Their physicians were credible, they were professional and capable. And despite, like I say, levying of sanctions and the absence of support from the major world leaders, they have excelled and shown that they have by participating shoulder to shoulder with the industrialized country-trained docs. But taking a step back, they've been very innovative. I was very impressed to know that during the very early stage, maybe 16 months ago, they incorporated into their medical school training a requirement that students pair up and go into the community and door to door offer testing. They were using the PCR COVID testing and to recommend treatment. I don't know if they use ivermectin or whatever, but they were proactive. In fact, there were parts of England or the United Kingdom that adopted that particular logistic strategy of sending the medical students into the community. Why is that applaudable? Too many times when we educate young people, we leave the human part out. We have them memorize anatomy, we teach disease, we do virtual things, but very seldom are they asked to face a living person and literally do the diagnostic skills that we're all supposed to be trained to do. And that is listen to the patient's symptoms, look for the patient's signs, and then integrate that information for a diagnosis. And so many young doctors are leaving steps out. that they do telemedicine or they do some kind of computerized diagnosis. And where's my evidence? The COVID-19 pandemic. You had to have a cough and a fever to even get tested. That's backwards. No one teaches medicine that way. You're supposed to listen, look, and then decide, not decide and then look. That's ridiculous. So Cuba, salute. I applaud them. And my understanding, Mauri, is there are efforts to initiate vaccine manufacturing. Of course, the information I get would be third hand. I don't have immediate contact, but their scientists are capable. I would think the only limitation for them arriving with a stellar product would be availability of materials.
Mm-hmm. This next question, and we're winding down now. It's off the COVID-19 grid, but it's very relevant. Labor, healthcare, and other advocacy groups are calling on President Biden to invoke the Defense Production Act to stop the shutdown of the largest U.S. generic drugs plant at the end of this month, a manufacturing plant located in West Virginia. 1,500 people are reportedly on the verge of losing their jobs as the plant outsources its manufacturing to India. Now, from what I've been reading and hearing, India has been having a hard time keeping up with the manufacture of COVID vaccines for its own domestic population, but I digress. The headline of an article published in the July 23rd edition of The Nation reads, quote, "Closing the largest generic drug plant in the U.S. is a sick joke. But Joe Manchin," that's Senator Joe Manchin's daughter, a company executive, is laughing all the way to the bank. Now, many would argue, Dr. Boles, that this is a capitalism at its best. The critics of this move argue that it will leave the U.S. with virtually no domestic production of generic pharmaceuticals, threatening the supply chain for essential drugs. What are your thoughts?
Wow, you're really hitting a point that grieved me almost 2 decades ago. The focus away from providing medication at a reasonable cost in the United States. I don't know if you know, but there were groups that generated things called the pharmaceutical RX card and other types of cards. You don't have to have a membership, but these groups had the very much interest that you mentioned. What good is it to have a medicine available that you can't afford to take? So there are some nonprofit companies that will provide these code numbers, where there are philanthropic groups that will co-fund the purchase of medications through the card RX. So folks, if you don't know about it, please inquire. The card is free. The comment you made about closing the West Virginia generic medication production is grievous. Too many people have been, I'll say American people that I've worked with clinically, have the opinion that generic is not as good as brand name. And part of that has to do with marketing. Mm-hmm. If you watch television, you can learn a whole lot of pharmacy. They will tell you what can be complementary to a bipolar person. It tells you your blood pressure medicine you need to try and tell your doctor you want. It will tell you all of the fancy diabetic medications that can be used. But guess what, folks? If you don't have insurance, and if you are a person of low income, meaning less than $30,000 a year, and there are many in many states I've worked, you don't even have access to what the television told you about, because hospitals are operating on a formulary, which is a fixed list of approved medicines. So there may be 30 plus medicines for diabetes type 2 that we know that can prevent kidney failure, heart failure, amputations. You can't have them because it's not on formulary. And what you can have is generally generic. Generic is any medication whose formula patent has run out. So once my patent is expired, I can access through Freedom of Information Act and other pathways to get the formula of what the brand name medicine used to make the medicine. The caveat here, though, Mauri, is often these high-end pharmaceutical companies have the newest equipment and have a certain kind of cooling chambers or heating chambers or drying rooms, and the manufacturer generic may not have that minor nuance. And therefore, FDA allows a plus or minus error in a generic. Now, many people don't know this, but there are certain drugs you cannot buy generic. One would be Dilantin. Dilantin is an anti-seizure medicine, and it is so sensitive, or the brain is so sensitive to minor variations. Dilantin cannot be made in a generic manner. It must go exactly as the manufacturer original manufacturing processes. So we don't usually talk about processes, but that's the biggest difference in generics, is the nuances and processes. When we lose the ability to make generic medication, there is a whole population of people who will not be able to afford their medicine, period. So I don't care whether they move it to India or to China or wherever, you're losing the ability to first quality control that if in one case someone is using ethyl alcohol to precipitate something and your manufacturing processor changes it to acetone or ethanol, who's to say? I mean, they're both volatiles and you can chemically describe it, but biomechanisms can be very sensitive, and manufacturing processes is what determines that. So it's very, very grievous that America would give up that quality control potential and send that to somewhere else.
Short answer, does America need universal health care?
Yes.
Mm-hmm. Any parting thoughts? Any advice for our brothers and sisters in South Africa, which I understand, and under some very challenging circumstances, has been able to vaccinate 6 million of its people? Any advice?
For those who are not vaccinated, or vaccines are not available, or for whatever reasons you cannot respond to a vaccine, please ask your powers that be for ivermectin, because that would be a major support to those of you who do not have other protective means.
Okay, Dr. Boles, I think what we have 2 minutes left. Any final thoughts you'd like to convey to our listening and viewing audience on this topic of today, the coronavirus pandemic, a global perspective? Any parting thoughts? Any closing thoughts?
We are in difficult times, but not for the reasons that you would hear announced on your mass media. This is a time when you need to look at your body as a sovereign entity, look at your community as somewhere to be supported. So instead of looking outward, I'll invite all of my entrepreneurial people to start looking for sources to help yourself.
Mm-hmm. Okay, we want to thank our guest for today, Dr. Velva Boles. As you all have been able to deduce, a very highly qualified voice and perspective on this issue of vaccines, on this issue of medical care on so many levels. We really appreciate and are proud to have a sister like you in the wings, Dr. Boles.
My pleasure.
Yes, indeed. So this will conclude today's broadcast. I want to end, as we normally do, with a little prayer verse from the Noble Quran. Bismillahir Rahmanir Rahim, which means in the name of Allah, the Beneficent, the Merciful. Wal Asr, Innal insana lafi kusr. Illa alladhina amanu wa amalu salihati. Wa tawasaw bil haqq. Wa tawasaw bis sabr. Which means, in translation of the meaning, by the token of time through the ages, verily humanity is in loss, except those who believe and do good, and exhort one another to truth, and exhort one another to patiently persevere. For those of you in the Western Hemisphere where I am located, may your day be blessed. And for those on the other side of the world in South Africa, where it is now night, may you have a peaceful night's rest and a happy morning's rise once you go to bed. Peace be unto you. Assalamu alaikum.